In a previous show, we looked at the access preparation in terms of the concepts and tools. Let's look at these concepts and tools in this segment and see how we can utilize them to cut access preparations into the maxillary teeth. Here's a case that was published in the Journal of Endodontics in 1994. This case was done by my friend Francesco Mangani, and you can see it's a very unusual central incisor. In fact, this right maxillary central incisor is a dens indente. It's a virgin tooth, but through the lingual groove, there was an ability for microorganisms to get into the pulp chamber, and you can see that there's multiple canals, there's internal resorption, and there's a diffuse asymmetrical periradicular lesion. Well, as work is continuing, you can see two canals have been negotiated, shaped, and three-dimensionally filled. And you can see the anatomy off the far left system. You can see the resorptive area has been obturated, and two more systems were identified. And if we look at the photograph, you can see that there is a facial and lingual branch making this central incisor a four-canal system. We'll skip right to the one-year recall, but Francesco exquisitely restored the tooth, and you can see that restorative work, it shows up quite nice radiographically, but Francesco's a marvelous operator, and you can see in this recall image that a significant amount of bone fill has healed around the apical region, both apical and laterally. So complete endodontics is a absolute necessity to get bone to heal. If we look at our first movie today, we'll look at this maxillary first molar on the radiograph, and you can see that there's a restoration in the occlusal table. You can see the pulp chamber is quite narrow in its occlusal gingival height. And again, you can begin to interpret how those canals bend about mid-root and start to angle in abruptly into the pulp chamber. These are the triangles of Denton that we've been talking about. So here we are opening up a partially vital tooth. You can see the vascularity. The tin file is off axis, so that means I can use the X gates to begin to pre-flare the orifice. If you lose a restoration, no problem. As long as you have a reservoir for your sodium hypochlorite, you can go ahead and fulfill your endodontic objectives. So now we can just finish the access, and we can use the diamond with the Stropco. The Stropco is the item I identified earlier that can collimate air through the white mac in this case. We're using the surgical length diamond to flatten that axial wall and to improve access into the area of the MB2. We know that over 90% of all maxillary molars have two systems in their mesial buccal canals. So flushing is important, and after we've pre-flared the MB1, we need to start thinking about how can we expand and get into the MB2. The MB2 is too small at this point to accommodate an X gates or a ProTaper Shaper X, so I have to go through a series of hand files very rapidly, turning them clockwise, then counterclockwise, so I can make some space. I don't want the instruments to feed deep into the canal. We're only trying to make some space in the coronal 1/3 of the root. So by using a series of hand instruments, clockwise, counterclockwise, cut, back them out, cut in, back it out, I can make a little shape restricted to the coronal 1/3 of the root. Now that I have some space, I can work with the assistants to benefit the economy of time and load up, in this case, the auxiliary X. The X gates can come in and spin at 500 RPMs as we've described, and I can begin to paint and brush and expand and flare the orifice. I want to move that orifice further away from furcal danger. Remember that MB root has a big furcal side concavity. Flushing along the way kicks out loose debris and allows for better visibility. But again, notice as we drag that butt of that instrument up that axial wall, we're smoothing and refining. What is always interesting to colleagues who take classes, that if we just take a little bit of time and pre-flare the coronal 1/3 of roots, notice how the tin files drop almost to the entire working length with really almost no effort. We're probably only about 1 millimeter away from the radiographic terminus and being at the desired working length, all because we knew how to do both coronal and radicular access. Well, if we look at the post-op, the endodontics is straightforward, but I want to just point out, look at the axial walls. They're flat. Notice that the access cavity has been expanded to remove the triangles of dentin, and notice that we have good shape flowing through the canals exhibited by the obturation right to the terminus of the three systems. Notice how the MB1 and MB2 merge in their apical extent. Here's a maxillary first molar, and you can see there's endodontic involvement radiographically, and of course the vital pulp testing condemns the tooth endodontically. It's a lesion of endodontic origin. I take a lot of crowns off, and that would be another lecture at another time, but by taking the crown off, you've made the tooth materially shorter. A shorter tooth means oftentimes you can work with 21 millimeter instrument files instead of maybe 25 millimeter length files. And the shorter the file is, the closer our fingers are to the distal extent of that instrument. That means greater control. You can see that there's lesions around the root apices approximating the maxillary sinus. So by taking this crown off, I'm going to not only have shorter instruments that I can use, but I'll have a better understanding of the emergence profile and how that tooth comes out of the free gingival margin, because I'll have unsurpassed vision of the prepared abutment. Let's take a look. So here we are immediately coming in to the MB. Notice the file's off axes, so we can immediately hold the handpiece at that same angle. The angle of the file is the angle of the handpiece. Here you can see we're brushing out of the canal, a little bit of tapping in, a little bit of cutting in, and then more brushing and painting and marrying that axial wall to the pre-flared orifice. Notice how the instrument went to length almost immediately once the orifice is pre-flared. Now when we're pre-flared, the neat thing is we can start to look down that MB1 and get better orientation off towards the MB2. Here we are with ultrasonics working at low intensity. Notice the strop goes blowing air in there, so I have unsurpassed vision as I sand along. There it is. There's the MB2. So just by understanding to do a little sanding action and remove a little overlying lip of dentin allows us to uncover the orifice, and here's a tin file starting to move. I'm using in this case a Gates Glidden 1. A GG1 is only a half a millimeter, but it begins to expand and flare that orifice. And of course, as I expand the orifice, I can see that I need to come back and refine my access, because I have a little deficiency still in the access preparation. So here's the surgical length diamond, again flattening and flaring the mesial axial wall. And as we now begin to look down into this access cavity, I think any dentist listening to this discussion would say, I could do that. And the idea is, if you just think about your access cavities as a step that needs to be expanded a little bit, maybe beyond what you previously did, and then if you have these ideas on how to finish the access, you're going to do better endodontics. Notice the finishing is done with two instruments. I keep repeating, the surgical length diamond, and in this case we use the auxiliary gates. We could have used the auxiliary pro-taper shaper. Well, we can go ahead and provisionalize the casting, but you can see 4 systems, 5 portals of exit, and this is what makes endodontics fun. Hopefully, in the examples you visualized, you've noticed how the various tools and concepts come together so we can get a predictably, successfully complete access cavity. With these concepts in mind, certainly you're going to discover more MB2 orifices in the days ahead.